Thank you very much. I will try to share my screen. Is that visible?
Yes, very much.
Yeah. All right. So hello to everyone. So before I go into the introduction of the session, I would like to start with the case so that I don't give away what the case is about. So this is about a lady, 40 years old lady who presented to the emergency with a collapse and fall at the market. And so you go and assess her in the emergency, and so she's still confused, looks dehydrated, and the GCS is around 14/15. Airway is patent, breathing is good, and there's no problems with that. The blood pressure is a bit low, around 84/60. The heart rate's 96. Temperature is okay. Respiratory rate is 20, and a BM of 4.5. Abdomen just slightly grimaces on deep palpation, query tenderness, and apyrexial since they have found her at the market, and vomited twice to the way to the hospital. Bystanders deny any seizure-like movements and incontinence. So at this point, what does it look like? What would be the first working diagnosis? So I'll go back the slide. I'll keep it here. And so if you can just put in something on the chat box. Yeah, someone's mentioned infection. Yes, that could be one of the things. Collapse secondary to hypertension. Yes, it could be. It could be just the hypertension, orthostatic hypertension, or something like a POTS, which could lead to collapse, like the postural orthostatic tachycardia. AAA is another diagnosis we could think of with the abdomen tenderness and hypertension. Saturations are fine. Saturations are fine. No problems with the breathing. SpO2 would be something around 96, 97%. Subarachnoid, well, it could be. She doesn't complain of any pain and any headache, but she's confused. She might not give a complete history. So we'll move on. Acute abdomen, yes, looks likely. So sepsis looks likely. Infection, something else. So what I would suggest at this point, the most the most convenient thing to do, or the safe thing to do, would be to treat as sepsis at this point. But while we are at it, probably just go through her past history and background a bit as well. So treat as sepsis. She's unable to give any further history. GP notes are looked into, and they say that she was generally fit and well till the last 6 months. In the last 6 months, she's had worsening lethargy and weakness and orthostatic hypertension, anorexia, losing weight, 6 kilograms in 3 months. And on her blood test, it was seen that she had a raised TSH of 15.76. So the GP started her on levothyroxine, and it was dispensed 2 days back. So any ideas now? Anything?
Yeah, it's around about the same.
Sorry. I think someone's mic was on. Someone trying to say anything? Sorry. Mixed edema coma is one possibility. Yes, we could think that the hypothyroidism has led to this. It's a possibility that the hypothyroidism has led to this, but wouldn't say she's comatose or she's in a mixed edema coma yet. Anything else? Any other? Any other thoughts that come to your mind? Addisons, yes, that's about it. Yes, she's losing weight. Although she was hypothyroid, she was started on levothyroxine, but she was losing weight. She was orthostatic. She was having orthostatic hypotension. She didn't look hypothyroid from the history, so it was something else happening. So what is the best way to manage this patient? Oral levothyroxine, IV levothyroxine, IV fluids, oral steroids, IV hydrocortisone, IV antibiotics in the line of sepsis. What would you think? Yeah, IV hydrocortisone. Yes, that's the first thing that comes to mind. Yes. So IV hydrocortisone and oral steroids, fluids, fludrocortisone, IV antibiotics. So all of them are an option actually. So IV hydrocortisone is the first line, has to be given, but in the long term, she will require oral steroids and fludrocortisone. We will give some fluids in the acute phase as well, because we need to treat the hypotension and probably the underlying hyponatremia as well. And IV antibiotics are still an option, because if this is an Addisonian crisis, we will discuss that this has to have a trigger. There should be a trigger. So triggers of Addisonian crisis. Number one is infection. So we still have to treat an underlying infection, which we don't exactly know the cause of yet, but we have to treat an infection. Vomiting, diarrhea, dehydration, all that can lead to Addisonian crisis as well. So all that can lead to hypotension in the patient presenting with the crisis. Major stress, like infection, like anything else, like a trauma or an accident, or even anxiety as well. And operation, accidents and trauma. So what this list doesn't mention is that starting hypothyroid medications can be a trigger as well. So that could be one of the triggers that has caused this. Starting her on thyroxine would increase the metabolism for the patient, and she will go into an Addisonian crisis. So the immediate management is 100 milligrams of hydrocortisone IV or IM, whichever access you've got, and then to continue with maintenance dose, and then normal saline infusion, as in how much is required to correct the dehydration and the hypotension. And the blood glucose is another thing that we have to keep in mind and treat hypoglycemia as in how necessary. So what are the features of Addisonian crisis? So we've already seen that: shock, low blood pressure, confusion, reduced level of consciousness, abdominal pain, including acute abdomen, nausea, vomiting, and biochemical abnormalities like low sodium, high potassium, and low glucose. So hyponatremia, hyperkalemia, and hypoglycemia are all found in Addisonian crisis because of what happens. What is the lack of cortisol and aldosterone. So I'll go back to my first slide. Sorry. So this is about Addison's disease. I skipped this because I didn't want to give away the answer. My name is Dr. Sabyasachi Mitra, and I am one of the IMT1s in Queen Elizabeth Hospital, Gateshead, and that's my email ID. So I'll move down back. Sorry. So our learning session today involves learning a bit about the anatomy and the physiology of the Addison's disease, of the adrenal glands mainly, and then to learn the presentation, the investigations, and the management of Addison's disease. So the adrenal anatomy, everyone knows about this. It's the adrenal cortex and the adrenal medulla. There are two parts to it, and the cortex has three parts of it, three zones really, which secrete three different types of hormones. So the mineralocorticoids from the glomerulosa is the aldosterone mainly, and the glucocorticoids are secreted from the fasciculata. And the adrenal medulla is involved with the other neurohumoral control with the adrenaline, noradrenaline, and dopamine. So I'll move ahead. So the cortisol, the glucocorticoid, is really controlled by the hypothalamus pituitary axis. So the HPA axis, that's how it is controlled. The CRH is the cortisol releasing hormone from the hypothalamus, which induces the release of ACTH from the pituitary, anterior pituitary, which in turn releases cortisol from the adrenal. And all of this has a negative feedback when they are in the bloodstream. So that's how cortisol is secreted. The renin-angiotensin-aldosterone axis is a completely separate axis. So the aldosterone, which is the mineralocorticoid, is not under the control of the pituitary. It is under the control of the kidneys mainly. So the kidneys secrete renin, which then is converted, which then converts angiotensinogen to angiotensin 1, and then angiotensin 1 is converted to angiotensin 2, and then that stimulates the release of aldosterone. So they are completely separate axis and separately controlled. So that's how it is controlled. And what the aldosterone does is it increases the water retention in the body. It increases the sodium. It keeps the blood pressure high, and it releases the potassium in turn of it. So in exchange of sodium, it releases potassium. So what happens if there is a deficiency? So the adrenal deficiency can be of 3 types. So it can be primary, which means that the glands are involved. So the adrenal glands are not working enough, and they are not producing enough cortisol. They're not producing enough aldosterone. And that's why they are not retaining enough water to control the blood pressure. And they are not retaining enough sodium, and they are not losing enough potassium. So they will have high potassium, low sodium, and low glucose as well, because the cortisol also helps the glucose metabolism. Secondary is due to the pituitary problem, getting like there is less ACTH production. So the aldosterone is not affected in this, or the tertiary, which might be due to the steroid medications leading to complete negative feedback of the pituitary. So all this does not involve the aldosterone. So it does not involve the mineralocorticoids, and the blood pressure is not that low in these situations, and the potassium is not that high, or the sodium is not that low. Although cortisol does have a small effect on that, but since the aldosterone axis is still working, it is spared. So those are the differences between the chronic Addison's disease and the Addisonian crisis. So a crisis would be more like a hypotension, shock, abdominal pain, nausea, vomiting, and there might be pyrexia, there might be fever, infection underlying, and confusion and coma as well. In the chronic phase, you will more or less find hypotension, postural hypotension, weight loss, and abdominal pain, nausea, vomiting, and depression, hyperpigmentation. So that's more or less a type of a mnemonic. So Addison's, you will find it will be mostly autoimmune. It will have abdominal pain, and it will also have an ACTH simulations test, which we will learn about later on. And there's this dark skin for hyperpigmentation. There is this weight loss and orthostatic hypotension, and salt craving, low sodium, and hyperkalemia as well. So causes of Addison's disease is mostly autoimmune, and it can be due to other things like congenital adrenal hyperplasia. It could be due to tuberculosis, infections like tuberculosis, meningococcus, and Haemophilus. We know about Waterhouse-Friderichsen syndrome, where there is bilateral adrenal hemorrhage causing adrenal deficiency. There can be adrenal metastasis, there can be infiltrative diseases like amyloidosis, hemochromatosis, and it could be iatrogenic as well. So how do we investigate? So the investigation is mainly due to, we can do the serum or the urine cortisol. So if the cortisol level is low in the random or in the 24 hours, then we can think of Addison's disease. We can check the plasma ACTH, and if that is low, we can think of something happening in the pituitary. ACTH should be high in Addison's disease due to adrenal problems. And short synactin test is stimulating the adrenals with a synthetic as ACTH to see if there's increased cortisol release with the ACTH. If there is, then the adrenals are working fine. If there is not, then the adrenals are not. So, and sodium and potassium levels might be deranged, sodium low and potassium high. So blood glucose may be borderline, and there might be other problems like hypercalcemia, anemia, and raised TSH as well, as we saw. So investigations, as I mentioned, cortisol has a diurnal variation, so best measured around 9 a.m. That is the highest level. And so it reaches highest at around 8 to 9 and reaches lowest around midnight. So if it's less than 100, then adrenal insufficiency is very likely. If it's 100 to 500, then it is possible. Greater than 500, it is unlikely. So short synactin test, as I said, we give a synthetic ACTH and see how cortisol respond. So if to synthetic ACTH, if there is rise in cortisol, then we would say then the adrenals are working fine. Then the problem could be something in the pituitary. And if it doesn't work, then the adrenals are in a deranged condition, and then we can say it's Addison's disease. So that's the same thing. So management of Addison's disease. So we give hydrocortisone, and it is usually to replace the glucocorticoid, and fludrocortisone for mineralocorticoid replacement. And dehydroepiandrosterone can be given for androgen replacement. And it is important that we counsel the people with Addison's disease to have increased corticosteroids cover during physical stress, illness, injury, infection, surgery, and also to recognize symptoms of adrenal crisis, and to have a medic alert and a steroid treatment card, or something to recognize them in the community. So glucocorticoids replacement, that's the dosage, usually given in divided doses. Just to remember, just the main thing from is that we give the highest dose in the morning, like 10 milligram on the morning at waking, and then 5 milligram at noon and 5 milligram in the early evening. We do not give any dose like past dinner time, because then the sleeping pattern will be just disrupted. The patient will not be able to sleep. So that's more or less what I had to say about this. Any questions?
Any questions at all?
You can type in or you can shout out.
We've got some time. Mitra's finished a little bit earlier.
Okay.
So
I could go back to the slides, like the heavy slides, which might have taken some time, like the investigations probably.
all right. I mean, we'll have a bit of a poll as to what people want.
Mm.
Would you like to go through some of the slides? And again, an option is perhaps I could show you some interesting ECGs, and you could type the answers in the chat box. So please be quick in your responses as to what you like, majority. until we have our next speaker in about 15 minutes.